Good morning. We're back talking about TMJ disorders or temporomandibular disorders, TMD. This is part of MSK2, and we are wrapping up our semester this year. So let's talk just a little bit about the TM disorders and the categories of disorders that we can find in this area. So if we think about our referred non-radicular pain, we can have pain that's generated from the cervical spine, which can be referred to the angle of the jaw, and this is at the C3 level. We have pain that can be referred to the teeth or from the teeth up into the facial area, and we have the muscles that can refer pain. The temporalis can refer pain into the ear, into the jaw joint. It can refer pain into the upper teeth. The masseter can refer pain to the upper or lower molars. The pterygoids can also refer pain into the sinus area. This is from Travell's manual, which we can find on triggerpoints.net, which is a very good resource for you to use in the clinic. I use it on the iPad and show the patient the referral patterns from the muscles that I'm looking at. If we look at neurogenic pain generators, we see that we can have neuralgia with the trigeminal nerve that will give a sharp, shooting, lancinating, drop you to your knees type pain anywhere in the face. It can be usually along the V3 distribution of the trigeminal nerve. We have the geniculate nucleus that can create shooting neuralgic pain, and then we have the glossopharyngeal nerve that can give pain into the tongue, and again that's kind of a sharp shooting pain that can occur, shooting pain into the tongue. We can also have pain generated from tumors, anywhere from tumors in the mouth to rhabdomyomas, which are tumors of the striated muscle, and that can create neurogenic type pain. We can have vasculogenic pain from arteritis, which we can have a carotidynia, where pain is generated from the carotid artery and referred into the face, as well as temporal arteritis, which actually can be a severe problem that requires medical attention. So let's talk about what problems can occur in the jaw joint itself. And one of these conditions is primarily a articular disc displacement. And that is a displacement of the articular disc, and in this position, or in this example, we're looking at a sagittal view, and the disc, the posterior band of the disc, should really sit at the 12 o'clock position, and the anterior band in about the 3 o'clock position. So you can see in the phase 1, the disc is starting to slide a little bit anterior, but more to the medial aspect. Here on the lateral side is the lateral collateral ligament, and the pterygoid, the lateral pterygoid, attaches to the anteromedial part of the disc, and hyperactivity in that area, as well as parafunctional activity, can start to loosen the lateral collateral ligament. Also, our temporomandibular ligament runs in this orientation, and if we have laxity there, the condyle will start to migrate posteriorly, and you lose this nice, tight orientation of the condyle disc temporal bone complex. We usually don't have pain or noise in the joint during this phase, and the patient typically does not seek treatment. During phase 2, the bilaminar tissues lengthen, allowing the disc to migrate both anterior and further medially. Now we start to get some tenderness along the lateral collateral ligament, and we start to get reciprocal clicking, where as the condyle rotates under the disc, it will recapture the disc, and then the disc condyle complex translates on the articular eminence. Again, the patient typically does not have pain during this phase, but notices popping both with opening and then with closing. And with closing, the popping will occur as the condyle moves posteriorly off of the posterior band of the disc. Now in phase 3, we have significant overstretching of the posterior and lateral ligaments, and the disc will stay anterior to the condyle until the end of range, when the condyle will snap over the posterior band of the disc, recapturing the disc. That will happen late in the range, and the closing click will happen will happen early. So you'll wait a long time before the condyle will recapture the disc, and then it won't stay on the disc very long, and it will have an early closing click. So late opening, early closing is in phase 3. The lateral pterygoid, which typically acts eccentrically, the superior band acts eccentrically to help control the translation and movement of the disc, becomes inactive. And during phase 4, there's minimal to no disc sounds. The posterior ligament is overstretched completely. The disc can crimp or become deformed, and the mandibular head actually will flatten. Sometimes there's beaking, where you'll have a osteophyte formed over the condylar head, and you'll have possible perforation of the posterior ligament. You can see here the lateral collateral ligament is completely stretched, and the disc is resting medially to the mandibular condyle. So these are 2 YouTube videos that we'll watch in class about the disc being recaptured and then the disc being displaced. So anterior disc displacement with reduction and anterior disc displacement without reduction. So if we talk about our subjective examination, we talk about Larry. And Larry has occipital pain, headache that starts in the posterior aspect of his head, as well as mandibular pain. So if we look at Larry, we can rank order our pain generators from the C2-3 facet, C1-2 facet, to the TM joint. We need to examine that and rule it out. Less likely 2-3 disc or vascular has been ruled out. So Larry's activity limitations is that his pain is present at the end of the day with various neck movements, and the facial pain is worse after eating or brushing teeth. The patient who has pain that's referred from the cervical spine into the face will not have pain with functional oral facial activities. With Larry, his 24-hour pattern is that the headache is present in the evenings after work, but the facial pain is worse in the AM. So we need to think about why that's occurring. With most people, if they are brushing and clenching their teeth at night, they'll wake up with their facial pain. So Larry's current history was that he had an MVA. He was able to remember everything about the accident. He experienced immediate posterior right neck ache, which is a poor prognostic indicator when the patient has pain on impact. The next day, cervical pain was worse, accompanied by a headache, and later that day he noticed popping in his right ear and right jaw. The patient returned to work 2 days after the accident. The headache has become intermittent, but the jaw popping is more noticeable in the past few days. So if we do our OE examination, we're going to look at our mandibular depression, our lateral excursion to each side. So we see on Larry he has 30 millimeters of depression of the mandible with right deflection. So we're already thinking that because the condyle can't move to the right, that the condyle can't translate on the right, that we have a right deflection and a limitation in the movement. So what we're going to expect is that, again, because the condyle cannot translate, we're going to have a limitation in left lateral excursion. Protrusion follows this pattern with 5 millimeters of protrusion with deflection to the right. And the patient does not have joint sounds. With palpation of the pain map, the patient has the following findings. 3 is the lateral collateral ligament. 5 is the posterior inferior synovial. 6, posterior superior synovial. 7, the bilaminar zone. And 8, the retrodiscal space. So if we go on to talk about systemic inflammatory conditions such as RA, gout, lupus, and ankylosing spondylitis, our patients with systemic conditions will have pain in the periauricular area, pain that varies with activities, and is better with rest. So eating, talking, laughing, singing, brushing your teeth, oral care. The patients sometimes have difficulty sitting through an entire tooth cleaning for an hour. Sometimes we'll separate those into two visits. During the objective exams, the patient may be unable to open fully or close fully, secondary to pain, and the pain with TMJ palpation with mouth open and mouth closed. They'll have pain with forced biting and with intrusive overpressure, which I actually don't do in the clinic. Capsular fibrosis due to micro or macro trauma. Sometimes these are our patients who've had surgery or the patient who has been in a car accident. And they'll have stiffness and pain. They'll have pain after prolonged capsulitis or immobilization. Pain such as subcondylar fracture. We'll have decreased mandibular mobility and deflection from midline, suggesting a decrease in translation. And you can feel this right to left side and see which one is not moving well. Hypermobility is a permanent elongation. This is our patient who has sometimes systemic collagen disorders or genetic collagen disorders such as Ehlers-Danlos or Marfan syndrome. And the patient will have this feeling of their jaw going in and out of place or history of catching with the mouth open. You'll see a large indentation posterior to the condyle with the mouth open and deviation to the opposite side and of opening. So depression is much greater than 40, can be as much as 72. And provocation test 4 has increased movement. That's our temporomandibular ligament when we take the mandible inferior and posterior. Patients can experience dislocations where they actually have the condyle lodged in front of the articular tubercle. And then prior to that, the patient may report a history of catching or feeling that the jaw is going out of place. So this is a picture of a patient with the mandibular condyles in the forward position. So the condyles are here, pushing the skin forward, and you'll see a hollow in this part of the face. Degenerative conditions. Degenerative conditions can start to occur after articular disc displacement has been going on for a while because we now have convex on convex joint surfaces and the patient has no cushion. So we have a lot of shear, which is translation under compression, and we will see that OA is present in even asymptomatic patients, so it's very difficult to know which of these patients that will go on to have pain and problems. So we'll see with these patients crepitus and global limitations of movement. They're functional, but their x-rays and CAT scans are positive for bony changes. Here are the contributing problems and contributing factors and risk factors, parafunctional activities. and psychosocial issues, life event stress scale,